of the elements of the workflow that people are usually a little bit confused about is most of us will not sit at the bedside every second and adjust these on a minute-to-minute basis. We will get those arterial blood gases or venous blood gases on like a every 4 to 6 hour basis. And based on that, we will have people adjusting the vent settings to achieve some of those goals. So it's less of a continuous titration, although there are critical patients who you will spend, 10 or 15 minutes at a time really trying to optimize their settings. But it's something where, unfortunately, we don't have the ability to sit with one patient and adjust their settings on a more frequent basis. So talking about overall components of what you need for a ventilator, you need, obviously, some source of power. You need to be able to control how you deliver gas. You need monitoring. And you need safety features. We might be in a situation here talking about, ad hoc or made ventilators not being able to have every single one of these. Some of them are more important than others, but obviously you need a power source. So a lot of modern ventilators are electrical, but old school ones you can still find examples of pneumatic driven bellows, which are kind of nice because obviously you don't need to have a wall outlet or worry about where you're going to get your power from for that. Most ventilators have an ability to blend gas. So to take room air and to take pure oxygen and produce some desired combination if you want to try and wean your FiO2. This is something that may not be entirely essential. If you have a patient who is sick enough to need a ventilator in the current situation, they're probably in most cases going to benefit from 100% FiO2. So as long as you have an ability to hook up a gas source for a gas accumulator, you might be able to use an oxygen tank or a pure wall outlet as well. You need to have some ability to humidify the gas that you're delivering. There's a lot of issues with temperature regulation and overall hydration status that if you blow dry 100% oxygen to people for a long period of time, you'll cool their body temperature and you'll also lower their body content. So you need the ability to humidify that. You need to have a circuit. So most ventilators will have an inspiratory limb and an expiratory limb hooking up to the ventilator. That comes together in a Y piece, and that's something that will then hook up to the breathing tube. During each cycle of inspiration and expiration, there are one-way valves to ensure that the push breath from the ventilator doesn't go into the expiratory limb, and then when they're expiring CO2, it's not going to get into the inspiratory limb for them to rebreathe. If there is any sort of mechanical fault in that, such that they rebreathe CO2, that's obviously less than desirable. A lot of anesthesia ventilators need to have a separate component that is a waste gas scavenger. So when you're using volatile anesthetics, you need to pass it through so you don't dump those into the atmosphere. That's not a problem with ICU vents where you're not using anesthesia gas. So most ICU vents will take that CO2 and put it directly into the atmosphere. For monitoring, you need sensors in an ideal situation. Some of the ad hoc ones you're seeing may not have those, but in the Cadillac ventilators, you have sensors that are able to, with a variety of mechanisms, detect gas concentrations. So they can tell you how much oxygen the patient's breathing in or breathing out, flow, which is more important in those modes where you're assisting a patient as opposed to controlling entirely. And then it's really important to be able to get a sense of what pressure their lungs are seeing and the volume that their lungs are seeing. talking about how each of the individual sensors work for those is probably a little bit outside of the scope of this talk. We can do one later kind of going over some of that. But most of these, I think you can probably get away if you use 100% oxygen with that. These are ideal, but less important in a triage situation where we're having people dying because they don't have access to any positive pressure ventilation. So from a safety standpoint, alarms are nice, things to tell you when there's been disconnection of the ventilator circuit from the patient, things to tell you when the pressure, the volume alarms and is too high. And then something really nice from the safety standpoint as well are filters, particularly in infectious conditions like this. If you can have viral filters, so like 5-micron filters or something like that, that you place between the patient and the circuit, then you can reuse these systems without worrying about contamination from other patients. Obviously, these types of things are much harder to manufacture. But if we had a solution that worked and we had excess filters, it'd be nice to put those on. So talking about all of that, sort of, in my opinion, again, this is just my thoughts, not necessarily suggestions or recommendations. The ideal make or vent would be obviously cheap. It would be easy to use. It would be portable. It would be nice if there was some pneumatic mechanism such that it was battery or AC free. It would provide some degree of PEEP, that really important positive end expiratory pressure that helps to keep the airways open in between each breaths, and it would be safe. So there are ways, we can talk in other working groups about how we can accomplish each of these things, but that to me would be kind of the ideal goal for what we would look at. And in fact, a lot of these requirements are met with what we call our Ambu Bag Setup. So we have, you might have seen this on ER or something like that, but you kind of have these self-inflating bags. They have the ability to be hooked up to an oxygen source. There's a reservoir bag. They self-inflate because they have one-way valves, so oxygen flows in and it can't flow out until you squeeze. Some of them have the ability to have a PEEP valve at the end. There's an expiratory valve so that patients don't rebreathe. And then there's a connection to a ventilator circuit. So this is a ventilator. This is something that I use to transport patients to and from the ICU and OR, or in an emergency when we're trying to resuscitate somebody. And obviously by squeezing this bag, you generate the pressure. Now, a lot of the solutions that have come online so far are some variant of an automated force that compresses this bag on a regular basis to essentially remove the person needing to squeeze it. Now, in the absence of complex sensors, you don't get a sense of the pressures you're delivering, and you don't get a sense of the volumes you're delivering. But this could be sort of the court of last appeal for a lot of patients who otherwise wouldn't get anything, and be kind of triaged as to not receiving positive pressure at all. So me, I'm interested in kind of ways to upscale these type of solutions and let the big Gs of the world work on more of the Cadillac ventilators. There is probably some, so there's a decent number of COVID patients who don't need hospitalization at all. And unfortunately, I think the numbers are a little bit worse than this. I think more 20% of people present to the hospital. And of those, maybe another 50% of them do fine with the nasal cannula or the face mask oxygen. And then of those, 50% will progress to the ventilator. And there might be a population in here that we can capture who would respond to that simple ventilation without the complex fancy sensors. And then there's going to be a component that's that much sicker and needs to go to the ICU and might die even with the Cadillac ventilators. So I think the best place to kind of target is work on increasing the supply of people who can receive basic positive pressure ventilation. All right, that was a lot. little bit longer than I had anticipated. Happy to open this for questions or clarify anything. And hopefully that was enough of a ground level overview to give you a thought at kind of everything involved in sort of the workflows.
Any other questions? All right. Well, Jeff, thank you very, very much for your time. This has been amazing to help us all kind of understand the pathology of the disease, as well as what ventilators will need to have or what to look for in them. I will stop the recording now, and then we'll get to post it online at some point in the near future. And Jeff's just writing up his Twitter handle at Jeff Tully MD. So if you want to follow him.
Yeah, anybody with any further questions or concerns, please feel free to reach out anytime.
Thank you, Jeff.
Thanks for all the work you guys are doing. I appreciate it.
Thanks, Jeff.